Hi everyone, this is Dr. Endocrine, Endocrinology and Metabolism. Today's topic is treatment of menopause. And we like to talk about this topic is because we feel that it's severely underdiagnosed, it's severely undertrained, even in residency programs as we speak today. In those patients who see their doctor, being a family practice, internal medicine, or subspecialty internal medicine, or even OBGYN, we feel that there's not enough awareness and alert towards the diagnosis of perimenopause, menopause, and the treatment of menopause because it's a big problem for patients that go at. I can assure you, if you are one of those patients who experienced that, this will bring a lot of attention and alert for you. Our goal is to educate everyone about how to go about the subject. We understand that menopause happens between the age of 45 to 55. The median age is 51, and over 80% of patients who undergo menopause have severe vasomotor symptoms. Those vasomotor symptoms are known as hot flushes, secondary to the loss of estrogen, vaginal health changes, vulvovaginal changes, dryness, itching, increased urinary tract infection, pain during intercourse. These are all the symptoms patients undergo, symptoms they give and the symptoms they have as they undergo a loss of estrogen through their menopausal years. Of course, other changes happen during these phases, so it's crucial that you identify these patients and target them and hit them head on because they need therapy, they need your guided attention because they will have a very difficult time transitioning to a non-hormone state from a hormone-rich state. It's time for the quiz. Let's have some fun. What is the age of menopause? Is it 30, 40, 50, 60, or 70? Kind of tricky question. Yep. Age of menopause can range anywhere between the age of 45 all the way to 55. The median average is about age 51. I hope you guys got the answer to that one. If there is one goal to be had in postmenopausal hormone replacement therapy, goal number one is to alleviate them from vasomotor symptoms of the dreaded, unwelcomed hot flushes. Here is another quiz question for you. When you start patients on hormone replacement therapy as a patient, what should be the goal? Should the goal be to bring your estrogen and progesterone biochemical laboratory testing to a normal range? Should it be to relieve your symptoms? And the answer is, which one? It should be to relieve your symptoms. You don't care about what happens to the labs. You want to relieve your symptoms. Because you can have perfect labs and bad symptoms. It won't make a difference. You went on hormone replacement therapy because you want to alleviate your symptoms of hot flushes and vasomotor symptoms. Estrogen can be had in many routes. It could be in a topical gel, or a lotion, or a pill, or injectable, or a vaginal ring. Although the oral formulation of estrogen and the patch formulation of estrogen is the best standardized reproducible value that we prefer in patients. Another quiz. How many routes of estrogen do we typically have? Oral, transdermal, lotion, vaginal estrogen ring, patch, or injections? And which is the most common desired way? All these routes do exist, but the most common desired way is either orally or through a patch because they're FDA approved and commercially available, clinically tested with efficacy and durability, and we do know exactly their side effects and profiles. In the past, years and years ago, we used to use conjugated equine estrogen, which has fallen out of favor. Now we use 17-beta estradiol, which is very similar to the biochemical composition of what estradiol is made in the ovaries. So it's considered bioidentical, and this formulation is commercially available, which is why we like to use it because it's very close or identical to the structural formula of what the ovary makes. Quiz question. When your doctor puts you on hormone replacement therapy, should you go on conjugated equine estrogen, which is old and outdated, or should you go on 17-beta estradiol, which is a bioidentical molecule very similar to ovarian estrogen? Hint, hint. Yes, you go for the 17-beta estradiol, which is bioidentical to the ovarian estrogen production. What about progesterone? Progesterone should be given in the format of micronized progesterone. It can be either given at the cyclic, which is 200 milligrams in certain days of the month during your cycle calculation, versus 100 milligrams per day, period. When we decide to discuss putting a patient on estrogen, we have to make sure there are no strong contraindications. Some classical contraindications for someone who goes on oral estrogen is active gallbladder disease, if they have gallstones, if these patients had a history of clots, history of stroke or a TIA, or history of breast cancer. And more importantly, guys, make sure you study patients to make sure they don't have a history of thrombophilia. What the heck does that mean? Yes, clotting disorders. Make sure they have no previous history of clot. Get a family history to make sure you understand that there is no immediate family history, mom or brothers or siblings or dad who had history of clots, or patients who have history of factor V Leiden as a mutation in a gene that encodes for a protein that increases the risk of clotting. Very important, because if those patients have those problems and you put them on estrogen, you substantially increase the risk of clotting in those patients for clotting disorders. So it's very, very important. Very important quiz question. Who should not be on estrogen? Is it an obese patient? Is it a patient who has uncontrolled high blood pressure? Is it a patient that has a history of stroke, history of recent heart disease, or history of clotting disorder, or breast cancer? Which one? All of them. All the above. If you have these risk factors, you should not be on hormone replacement therapy, because hormone replacement therapy increases the risk of all these little guys. I always believe if you prescribe a drug, you need to understand the drug's effects and the benefits it has on the endocrine system. When patients go on estradiol, the very first thing that happens, estradiol changes the way protein molecules talk to each other. For example, it immediately changes how the thyroid hormone sits on the thyroid receptor and how it's circulated, and how much free thyroid hormone becomes available. Therefore, if you're on thyroid hormone and someone puts you on estradiol, that needs to be evaluated very carefully by monitoring your thyroid hormone and looking at your thyroid labs more carefully, as you may require a higher thyroid hormone dose. Similarly, in those patients, the effect can be seen in a thing called cortisol. The effect of cortisol binding globulin, the carrier molecule that carries cortisol in the circulation, that can also get affected. Therefore, they can affect the way you measure your cortisol. So these are very important things that you need to take into consideration if you go on estrogen. Here's another quiz question. When you go on estrogen therapy and you realize you're already on hormone replacement therapy, should the dose of the thyroid hormone be increased or decreased? Which one? Your doctor puts you on hormone replacement therapy because of menopause, but you've been on thyroid hormone for years. Well, what happens is the dose of thyroid hormone should be most likely increased because it changes the thyroid binding globulin, making less hormone available as a free hormone and more as a bound hormone. So the answer is it should be increased. The dose of estrogen should be individualized, and that dose is specifically based on the patient's severity of the symptoms. The typical dose of 17-beta estradiol is about 1 milligram, or if it's in a patch format, it's a lot less, 0.025 versus 0.05 milligram of patch. Now, if you put a patient on estradiol, you have to ask the question is, do they have an intact uterus? Because if they have the intact uterus, then those patients should be placed on progesterone. And that progesterone can be placed at doses approximately 200 milligram in a cyclic fashion, or 100 milligram per day of micronized progesterone. You must understand the mechanism of these drugs before prescribing them. In those patients who do not have a uterus, there is no data or any benefits with putting someone on progesterone if they do not have a uterus. All right, here's another quiz question, guys. When going on hormone replacement therapy, estrogen, progesterone, what is the right dose? Well, the right dose is the high dose or the low dose. Well, the right dose is the lower dose. But if the patient has substantial severe vasomotor symptoms, then they should probably go on to moderate to higher dose because they can get alleviation of those symptoms faster. But you always want to start low and work your way up because it's much more safer and effective. Always keep in mind, the lower the dose, the better, because the higher dose estrogen taken orally can affect the liver binding proteins and coagulation factor, therefore increased risk of clotting. Yes, you've heard me correct. Oral estrogen can increase the risk of clotting, and that risk can be decreased by taking a patch format. Therefore, we need to take into consideration based on patient's risks. You always want to start slow and work your way up unless the patient has very severe vasomotor symptoms, in which you start at moderate to higher doses. When evaluating patients who are going into postmenopausal symptoms, if the patient does not complain of severe or mild to moderate vasomotor symptoms with no disruption in their sleep, their mood, anxiety, their energy, their fatigue, then you have to ask the question, what is the benefit of this patient undergoing such hormone therapy? Is it cardiovascular? Is it for the bone? Is it for the vitality? Is it for the skin? Always remember, when someone gives you pharmacotherapy, you have to see where the risk is. If the risk is here and the benefit is here, you have to ask the question, is it worth it? You always want the risk to be down here, the benefit to be up here to justify the therapy. For example, we do know that improvement of lipids do take place. But if patients have elevated cholesterol, they can actually go on pharmacotherapy, have lifestyle changes to improve their lipid profile. If they have loss of bone density or risk for osteopenia or osteoporosis, we have much better drugs than estrogen to help improve their bone density and their bone strength. Of course, I believe estrogen plays a great role in bone health, but then again, the benefits may not outweigh the risk in those subsets who don't have severe vasomotor symptoms. Another good question. Should all postmenopausal females be on hormone replacement therapy, regardless of symptoms? True or false? That's false. All postmenopausal patients do not have vasomotor symptoms. Some gracefully go through postmenopause with very little to no symptoms. Those patients do not need to be on hormone replacement therapy, although they can choose to go on vaginal estrogen creams to help the vaginal lubrication, moisture, and vaginal health and urethra, but they do not need to be on hormone replacement therapy. So hormone replacement therapy is not synonymous to postmenopause. You can't say, I'm postmenopausal, now I gotta go on replacement therapy. You should consider replacement therapy if you have multiple symptoms of vasomotor, hot flushes, heat intolerance, and all the symptoms that go with it. If you don't have those symptoms, you may want to consider not going on them because the benefits may not outweigh the risk at that moment. A typical side effect of estrogen is breast tenderness and discomfort and irritation, while progesterone typical side effect is bloating, which is very common in patients who go on progesterone. All right, here's a quiz question. What is the common adverse side effect that patients can complain about if they go on estrogen? Breast tenderness, breast fullness, fluid retention. What about progesterone? What symptoms should they consider? Progesterone is a steroid, therefore increase bloating, again fluid retention, and kind of feeling kind of yucky. So therefore, those are things you want to educate your patients, and the lower you start the dose, the less likely they'll have those symptoms. What is of interest is only 25% of patients who are symptomatic seek attention, and those patients deal with it. And unfortunately, they should not be dealing with it. They should seek help for it, and that therapies can substantially change and improve their vitality to lessen their stress and anxiety and make their functionality better with life and also at work. Initiation of hormone replacement therapy is quite very safe as long as they don't have absolute contraindications. Once again, those absolute contraindications is breast cancer, history of clotting disorder, family history of breast cancer, first relatives, history of smoking, morbid obesity, gallbladder disease, liver disease. These are very common things that you need to ask those patients, because if they have those risks, the risk of therapy is not worth it. Now, in what age category is it safe to put these patients on? Typically, the consensus data talks about 5 years of hormone replacement therapy being quite effective and safe. So therefore, if you put the patient on hormone replacement therapy 5 years starting the age of 49 or 48, within the first 5 years, the combined estrogen progesterone is quite very effective. Now, once the patient goes past the 5 years, the risk increases. It's believed at the year 4, the risk of breast cancer increases in those patients who are on the cyclic format of the progesterone and estrogen. So therefore, as you are going through the years of estrogen replacement therapy, you need to have routine breast examination. You need to make sure you have routine mammograms. You need to make sure you follow up with your doctor very, very carefully and not get lost to follow-up. Now, these therapies can be continued up to age 55 and sometimes up to the age of 60 if the patient has severe symptoms, because the hot flush symptoms typically tend to taper down to become less severe, although some patients unfortunately have these symptoms for 10 to 20 years post their last menstrual cycle. And in those patients, it needs to be individualized to see what risk factor they have. Is it safe to carry on the hormone replacement therapy for them? So exactly, that has to be looked at very, very carefully, and you would try to always give them the lowest possible dose to lessen the risk of those complications. Is hormone replacement therapy safe? True or false? The answer is it's safe. It's true. Hormone replacement therapy is safe unless there are absolute contraindications to the therapy. In the young age of 45 to 55, it's quite very safe. The longer you are on hormone replacement therapy, the higher your risk of complications, side effects can be. But initially, the first 5 years, it can be very, very safe. I can't tell you, in my practice, the biggest problem with menopause is sleep disturbance. As we know, our body needs rest and recovery. And if we don't have enough sleep, our body starts to fall down one by developing more propensity to autoimmune disorders, malignancy, illnesses, sicknesses, and lack of recovery. When patients wake up in the middle of the night with symptoms of hot flushes, vasomotor symptoms, at the moment they're about to go into REM sleep, from light sleep into REM sleep, they wake right up. As soon as they wake right up, guess what happens? They have to now go back to light sleep again, then to fall, and then 4 or 5 minutes later, they have another hot flush. So these patients hardly can ever go into restorative deep sleep. So when they wake up in the morning, they just feel absolutely exhausted. And that's because they cannot in any way get a meaningful restorative REM or deep sleep. This is why we are a big proponent of hormone replacement therapy in those patients who have sleep disturbances and hot flushes, because we need to restore their sleep so they can function correctly. All right, guys, here's another quiz question. What is the single most biggest problem with postmenopausal symptoms? The number one problem. That's hot flushes leading to sleep disturbance. Sleep disturbance is a major problem because when you cannot sleep, your body cannot heal and recover. If you cannot heal and recover, you wake up every morning exhausted, groggy, confused, mental fog, and you think, my God, what's going on with me? Why can't I do everything? I get 10, 12 hours of sleep. That's because your quality of sleep is very poor. That's because you do not get REM and deep sleep, which are restorative sleeps, which gives your body rejuvenation and energy. The single most problem with menopause, postmenopausal hot flushes, is sleep disturbance. If patient in the postmenopausal years do not have vasomotor symptoms and they're going to postmenopausal years, we believe that using vaginal estrogen is quite very safe and very, very effective. Of course, some systemic absorption can take place, but vaginal estrogen can be very healthy for the vaginal and the labial health because that decreases the vaginal thinning and also improves the lubrication for intercourse so they have less sexual dysfunction when it comes to that aspect of it. Therefore, that can be treated indefinitely as long as they want to treat those conditions associated with those symptoms. Right, here's another quiz question. How long can vaginal estrogen be given to postmenopausal female? 1 year, 5 year, 10 year, 20 year, or indefinitely? Which one is it, guys? The answer is indefinitely. Patients who would like to stay on vaginal estrogen can stay on it indefinitely as long as they don't have any active disease processes. And that's very important because vaginal estrogen is mainly absorbed locally. Of course, some can be absorbed systemically as long as there are no other risk factors, but it's quite very, very safe. So postmenopausal females can all go on vaginal estrogen with efficacy and ease, really no significant concerns towards any major side effects, although I encourage you to talk to your doctor because each case does vary. Cyclic combined estrogen and progesterone is a combined method of therapy. Although women do not like menstrual bleeding in the postmenopausal years, and therefore you can obtain that by starting at a low dose and up titrating a dose to avoid the vasomotor symptoms. These breakthrough cycles are uncomfortable, although most patients combine the cyclic estrogen progesterone with the best results. So therefore, if you give a high dose, it's more likely they'll have a bleed. The reason they're not having a bleed is because the continuous usage of progesterone does not allow the estrogen to sit on the lining of the uterus. So you're consistently shedding it at a microscopic level. Therefore, you do not have a regular menstrual cycle bleed, which is very much preferred by most patients. Intermittent cyclic bleeding happens typically in patients who are really starting out into the early postmenopausal years, and that typically fades away. It is quite bothersome when they're having a menstrual cycle but they're not expecting it. Therefore, starting at a low dose, titrating up effectively is very, very important. If the patient continues to have breakthrough bleeding, these patients need to undergo an GYN examination. That examination also constitutes of a pelvic or endovaginal ultrasound. This ultrasound is placed inside the vagina by looking at the uterus and the lining of the uterus and how thick that lining of the uterus is. This is why we give progesterone, because we don't want the lining of the uterus to become very thick. A thickening lining of the uterus is considered a term called hyperplasia. This hyperplasia, if left alone, can increase the risk of possibility progression into uterine cancer, which we take this very, very effectively. In those patients who have hyperplasia or thickening of the lining of the uterus with progressive bleeding, despite change of the hormone, some of these patients may need the endometrial biopsy to make sure we're not dealing with something more ominous. All right, here's another quiz question. Can patients get breakthrough bleeding on hormone replacement therapy? Yes, they can. That typically happens very early in the late perimenopause, menopausal years, and it tends to dwindle throughout the years. It's more common at high dose estrogen progesterone and much less common, and over the months to come it actually goes away. If postmenopausal bleeding continues, you need to make dose changes, and subsequently, if it continues, you need to have further evaluation to make sure your endometrial lining is healthy. When patients are taking oral contraception at a low dose and they reach the perimenopause to late perimenopause to menopausal years, they won't know if they're gone in menopause because the dose of the estrogen is so high it suppresses the pituitary hypothalamic axis, the FSH that comes to the ovary, and then they won't know because they just have no loss. They have such high amount of estrogen. In these patients who hit the age of 50 or 51, we are recommending that we taper them down and discontinue this medicine and understand and repeat their testing to see if they've gone in the menopause, because the high dose of estrogen through a birth control pill is not really ideal in a postmenopausal woman. And those patients who would like to go to hormone replacement therapy based on severe hot flushes or symptoms can then be transitioned to a much lower dose consistent with hormone replacement therapy, but not oral contraception. All right, here's another great quiz question. If you've been on birth control pills for years, for 15, 20 years, and now you're approaching your perimenopause, late, early versus menopausal years, you're at 50 or 51 or 49 years of age, how do you know if you're in menopause? Well, you just don't know that because the birth control pills are high-dose estrogen and progesterone, which block the hypothalamic pituitary axis to the adrenals. Therefore, your FSH cannot rise, therefore you're not going to get those hot flash symptoms and your body's not going to go through estrogen withdrawal. Yes, those patients cannot be detected on a clinical history because the birth control pills block that history. So what you do with those patients is you stop their birth control pill when they're about 49 or 50 or 51 years of age and approximately test them 2 to 4 weeks later with labs and estrogen and FSH values, and you see those values and make a decision at that point to see if they're the right candidate for hormone replacement therapy, which is a much weaker version of birth control pills. Here's a great topic of great controversy, which I'll take a lot of heat and discussion. No worries, here we go. When it comes to bioidentical compounding of hormone here, the major societies being obstetric gynecology, endocrine society, consensus data is clearly against compounding hormones. Wait a second. The reason behind it is that it's lack of consistency, lack of getting results, high variability, which can range between 60 to over 200% in dosing, lack of standardization, lack of sterility, and lack of reproducibility. These are the reasons why they're not recommending it. Now, there's nothing wrong with compounding as long as you cannot get your hand on the formulated drug that is commercially available and tested by the FDA. Since estrogen and progesterone is widely available all over the world commercially, then there's really no reason to put someone on compounded estrogen or progesterone for the reasons mentioned based on all society and guidelines given here too. And last but not least, These bioidentical hormones given by compounding pharmacies can be quite expensive and they're not covered by insurance typically. Therefore, it's out of a pocket. When you go on these bioidentical hormones, there is a big problem. You have to have constant testing, readjustment of the dose, make the changes, which creates a lot of time and headache and expenses, versus something that's been already proven, which is the commercially available 17-beta estradiol, which is bioidentical to the formulation of estrogen that comes from the ovaries. These are all soy-derived molecules when they're made, which is identical to the estrogen molecule. All right, major controversy. Is compounding bioidentical hormone per se FDA approved versus commercial estrogen, which is 17-beta estradiol and micronized progesterone? Which would you choose per FDA guidelines, Endocrine Society, and OBGYN Society guidelines to be as the modality of therapy? Do you choose the compounded version or the commercially bioavailable versions, bioidentical versions? Well, the answer is very straightforward. You choose the commercially bioavailable because they're reliable regarding their potency, efficacy, and their side effect profile is well known. They've been well studied. The reason bioidentical compounding, which is a misleading term, took place and took off so much is because back in 2002, when the Women's Health Initiative came with the data and it magnified and amplified the risk of breast cancer, prescription estrogen and progesterone took a nosedive. And subsequently, these compounding bioidentical pharmacies came up and start advertising their safety and efficacy, which has never been proven. There's never been randomized trial data looking head-to-head for these cases versus the commercially available products. So therefore, as the commercial estrogen progesterone took a nosedive, the bioidentical compounding world took a skyrocket rise, and that's why they're available here. In postmenopausal women, the question we always get is, I should be on testosterone, just like everyone else. Well, the answer is no. Testosterone, first of all, is not FDA approved to be used in women in a standardized postmenopausal female. Now, we're not against using testosterone in females, but not as a standard how we would recommend estrogen or progesterone in those patients. Therefore, in certain individual populations, testosterone can have an improvement in libido, sexual drive, and desire, but it's not standard of care using as a cookbook in someone who goes in postmenopausal years. How do we follow the success when we put someone on hormone replacement therapy? When patients are placed on hormone replacement therapy, we start with the lowest dose. For example, if it's oral, 17-beta estradiol, we put them on 0.5 milligram of estradiol. And then if it's a patch, we put them on 0.025 milligram patch. And then we look at their vasomotor hot flushes symptoms. If the hot flushes symptoms have drastically improved, we're okay with it. If not, we up the dose until we get resolution of the symptoms. And then we maintain this dose for years to come while monitoring them very carefully. The risk of breast cancer doesn't really start to increase, especially in those who are on progesterone, till year number 4. Therefore, routine breast examinations, follow-up with your doctor, mammograms, and ultrasounds are crucial. You got to get them done if you're on hormone replacement therapy. I'm not saying you shouldn't get it done if you're not on therapy, but it becomes more important if you're on hormone replacement therapy. All right, quiz question. How should you gauge the success when your doctor puts you on hormone replacement therapy? The success is it either through laboratory testing or clinical symptom resolution? Which one is it? Laboratory or clinical resolution? It would be clinical resolution of the hot flushes and vasomotor symptoms. We go after resolution, clinical symptoms. We go after subjective changes and improvements. That's how we know we're successful. And once we're successful on that, we will continue on the same dose for about 3 to 5 years or possibly longer based on your age. Factors to consider when you go on hormone replacement therapy in those patients who are on anticonvulsive for seizures. Anticonvulsive medicines are known to increase the hepatic metabolism of estrogen. Therefore, your estrogen content will become much lower and much less effective, so you may need a higher dose. In the same token, those patients who go on estrogen may need higher amounts of thyroid hormone because the way estrogen talks to the binding receptors and carrier protein called thyroid binding globulin. Yes, all you need to know is that if you go on estrogen, you're on thyroid hormone, you may need a thyroid hormone dose. Also, in those patients who drink alcohol, estrogen can transiently increase levels of those patients. Therefore, kind of want to make sure you don't really hit the alcohol that hard. You can drink, but just make sure it's not that hard because it affects your estrogen content concentrations in the body. All right, when you're on estrogen and progesterone, you need to make sure you have a mammogram follow-up breast examination. But the other part of it is uterine. You need to follow your uterine health. Estrogen lays a lining down on the uterus. This lining of the uterus needs to be shed every month, which is why you used to get your menstrual cycle. This loss of menstrual cycle now allows estrogen to build up and build up. That's why we give progesterone in a micronized fashion. This progesterone allows more a bleeding cycle in which a luteal phase causes your lining of the uterus to shed. When you give these small doses, you have consistent shedding without you really knowing much. But if you have breakthrough bleeding and bleeding which is abnormal, you need to have that evaluated. So don't take it lightly. Make sure you follow up with your doctor and ask him to obtain a endovaginal ultrasound. That means you put the ultrasound device, which is like a circular tube inside the vagina, which has the closest proximity to the uterus, because they need to see how thick is the uterine wall. If the uterine wall is thick, that's a concern, because those patients are high risk for developing endometrial carcinoma, and therefore they need to be monitored very carefully. All right, another quiz question. When you go on hormone replacement therapy, what are 2 things you should be very careful about? Number 1, you need to make sure you have your routine breast examination, mammograms, and breast ultrasounds, if indicated, and also monitor your uterine health, making sure you don't have excessive bleeding or breakthrough bleeding or bleeding postmenopausal. Bleeding in a postmenopausal state is not an accepted finding, because if you have that, you may possibly develop endometrial hyperplasia. That's thickening of the endometrial lining. Progressive thickening of endometrial lining can lead to hyperplasia, meaning thickness of the diameter of the lining of the uterus, and subsequently that increases the risk of uterine cancer. Therefore, you must follow up with your doctor. Do not get lost to follow up. Here's another quiz question. Should all patients, regardless of the uterine existence, go on progesterone? Answer is yes or no. Answer is no. Progesterone should be given to those patients who have an intact uterus who go on estrogen. So progesterone allows you to shed the lining of the uterus, because estrogen causes a lining that's laid on the uterus, and progesterone sheds that lining. If you do not have uterus, there is no clinical indication of progesterone in the female health. There is conversation and talk about progesterone helping patients sleep better at night. That data is very much refutable, and therefore progesterone causes bloating and retention of fluid. Probably not the best idea to give to patients unless clinically indicated. Remember, risk versus benefits. In those patients who have mood and anxiety and disturbances, the studies and data favor that some of these patients, or most of these patients, have baseline subclinical depression or anxiety, which now with the loss of estrogen, it just blossoms the symptoms. In these patients, we highly recommend to put them on hormone replacement therapy if there's no risk or contraindication. But subsequently, we also like to discuss the idea of putting these patients on non-hormonal therapy, such as SSRIs. Yes, these are medicines designed for anxiety and depression, which you can talk to your doctor about. You can be concurrently on these medicines very safely to improve your mood, because if your mood is bad, everything goes bad.